Welcome students. This class is for 4th Pharm D student as well as Pharm D post-baccalaureate students. Regarding clinical toxicology, already we have seen 2 classes. Today we are taking a class which is most interesting and as well as it has some importance in your university examinations. I have referred some university questions, not all, at least 4 years questions starting from 2021 to 2024, and I have seen that they have asked questions from this chapter frequently. So it is important for the Pharm D students, the clinical pharmacy students, to be more strong in their clinical toxicology, which physicians and other health supportive care workers need your support. So you have to be thorough with the clinical affairs about, especially today I have taken a topic in such a way in clinical symptoms and management of acute poisoning. Not all the drugs. I have selected paracetamol, acetaminophen. That is paracetamol, which is chemically it can be called as acetaminophen. Everywhere acetaminophen we used to add acetate amino phenyl group. And salicylate ASA, which is very commonly now we are using, and non-steroidal anti-inflammatory drugs, NSAIDs. These are also analgesic drugs, which category many drugs are there. So these are commonly used. So overdosage, self-medication may causes people to come with toxicity. So we should know about this in our fingertip actually as a pharmacist, clinical pharmacist. So I took this class for the Pharm D student as well as the Pharm D post-baccalaureate program students. So here I have taken past Kerala University of Health Science questions from paracetamol, acetaminophen, paracetamol, otherwise it is called acetaminophen, and salicylates, and non-steroidal anti-inflammatory drugs, NSAIDs. So in which I have seen many questions, at least minimum one question is asked in every year for both Pharm D as well as Pharm D post-baccalaureate students. See, the question, 10-mark question in September 2024, Pharm D, they have asked, explain in detail the clinical symptoms and management of acute poisoning with paracetamol, salicylates and ethanol. So ethanol combination which causes more toxicity, liver damages to paracetamol and salicylate. So they have added in such a way the question, 10-mark question. Then you can see 10-mark question again in August 2024 for Pharm D post-baccalaureate program. They have repeated the question, discuss in detail about acute poisoning with non-steroidal anti-inflammatory drugs. Just comes to the near to our place of analgesic, non-steroidal anti-inflammatory drugs as well as analgesic drugs. It's needed in that chapter, I mean. Next, explain paracetamol poisoning. Specifically they are asking, or they can sometimes ask, explain acetaminophen poisoning also they can ask. 5-mark question they have asked in August 2024. In the same question paper, they have asked 2 questions. You just see, Pharm D post-baccalaureate program. And discuss the management of paracetamol poisoning, 5-mark question in August 2024 Form D students, you just imagine in the same year, for both the batch of the students, they are asking these questions repeatedly, and the importance also. That's why I took this chapter. It will be useful for you to listen to this class and to revise your knowledge, and you have to listen to this lecture, and then you have to prepare your own lecture notes. That is very important. Explain the role of methionine. See again, methionine is also additional supportive for paracetamol poisoning with an antidote like N-acetylcysteine in acute acetaminophen poisoning, paracetamol poisoning. 5 mark question. June 2023 for Form D post-baccalaureate program they have asked. Discuss the management of acetaminophen poisoning. 5 mark question in June 2023 Form D students they have asked. And they have asked a 5 mark question in January 2023 for Form D students. Again in the same year. Discuss the clinical presentation and mechanism of toxicity of NSAID, non-steroidal anti-inflammatory drugs poisoning. 5 mark question they have asked. And clinical symptoms of management of paracetamol poisoning. 5 mark question July 2022 for Form D students. Discuss in detail about acute poisoning of non-steroidal anti-inflammatory drugs. 10 mark question they have asked in November 2021 for Form D students. Explain the symptoms of poisoning with non-steroidal anti-inflammatory drugs and how it is treated. 5 mark question November 2021 for Form D post-baccalaureate program. You see, this is very important topic. Discuss the clinical symptoms and management of acute poisoning with paracetamol. 5 mark question in January 2021 Form D post-baccalaureate program they have asked. So I have not taken almost only 4 years I have just seen, and they have referred, and there are many questions, up to 2015 in KUHAS. From 14 itself we have the question in their website. I have repeated questions are there, so it's interesting to study about. So today I cannot take on the whole all detail, but today I can discuss about only paracetamol, acetaminophen, and then we'll continue in the next class. So today, paracetamol, just listen to that. Paracetamol, everybody knows, it's an acetaminophen. N, acetyl, para, aminophenol is the chemical structure. A chemistry background pharmacist will be knowing. So paracetamol usually refers to or referred to as a acetaminophen, acetyl group, amino group, and a phenyl group, is a widely available non-prescription analgesic and antipyretic agent. You may be knowing about in 2020 it was the highest sales drug due to this corona. People were taking paracetamol enormously and got the toxicity also many. So it's important for us to know it's a common drug anyone can take and anyone is used to take from the OTC drug. So paracetamol is often used for the management of various conditions such as headaches, menstrual cramps, muscular pains, toothache, arthritis, and fever. So this is a tablet Dolo 650, we know very well, but it is many form tablet, different doses are also available. Paracetamol liquid also for children, infusions, when we have vials and ampules, suppositories, and we have sustained release tablets also, and advanced formulation like transdermal formulation like Panaflex, Paracetamol is also available, liposomal formulations. But you see, it may lead to hepatic injury, very dangerous, if used in excess amount or for prolonged duration. Somebody is using it in self-medication. It causes damage to the liver cells. Liver necrosis will happen. So first we should know how paracetamol works. You might have studied in your pharmacology and in your therapeutics, but still I want to just to give you some idea, just a small 1 minute, to state that its pathway. For example, it is then pathway, interesting pathway for prostaglandin pathway, because it is inhibiting the COX. That's by that it inhibits the production of prostaglandin, which is responsible for the inflammatory scoop and the pain. So you can see that in the picture itself it shows acetaminophen, paracetamol reduces the PGG2 co-substrate by means of inhibiting COX-2, cyclooxygenase enzyme inhibiting. Paracetamol thought to inhibit prostaglandin H2 synthesis via cyclooxygenase 2, COX-2. So that it's necessary for the student should write. You see, this is the area which I was meaning it. It can inhibit the production of prostaglandin. Even the lipid hydroperoxides, which also gives inflammation and severe pain, the stimulated by the leukotrienes or leukocytes platelets. You may be knowing about that injury, how the degranulation takes place and secretion of leukotrienes, prostaglandins, bradykinin, which causes various symptoms of triple response. So additionally, it may act as a reducing agent, lowering intracellular lipid hydroperoxides, which can affect COX-1 and COX-2, cyclooxygenase enzyme 1 and cyclooxygenase enzyme 2 activity can be inhibited. This is what we should know, that how it acts as an analgesic. Paracetamol metabolism also we should know what happens, how its biotransformation takes place in our body. The primary metabolic routes of paracetamol in the liver include glucuronidation or glucuronidation. You should write this word, that is glucuronidation, and sulfonation. This takes place and it can be excreted actually. Glucuronidation is very important, and sulfonation. 90% by glucuronide and sulfate metabolite, they are non-toxic. So it can be excreted in the urine. In the picture it is shown very clearly. But in other words, that is the round which I shown, 90% of them in normal doses. The process of glucuronidation transforms paracetamol into a molecule that is soluble in water. That is why It is enabled to eliminate via urine as shown in the picture. The sulfonation pathway is a minor pathway, but because more important at high doses of paracetamol. When you are overdosed, mistakenly taken, then you are coming to the production of NAPQI. This is conversion of paracetamol or acetaminophen by CYP 450 enzyme to N-acetyl para benzocunane imine, that is NAPQI. It is very toxic, but it can also be converted into mercapric acid as a non-toxic by conjugating with cysteine, but still if it is very high doses, it will go for damaging the cells of liver, hepatocnecrosis will happen. So you see, that is NAPQI, N-acetyl para benzocunane imine, dangerous compound. An arrow which I am showing there. It will damage the liver, causes hepatocyte necrosis, death of liver cells. That is what we want to say. Another route is associated with the hepatic enzyme cytochrome P450, CYP 450, which facilitate the production of the harmful metabolite known as N-acetyl para benzocunane imine, NAPQI. So this is the picture. Again the student can remember. Paracetamol enters into the liver and reaction with the glucuronides and the sulfate metabolism, which is non-toxic, water soluble in nature, and excreted urine, and even this dangerous metabolite which is produced by cytochrome P450 enzyme, NAPQI, that is N-acetyl para cunane imine, is also can be converted by glutathione. The glutathione have the capacity, even cysteine also have the capacity to convert into mercapric acid, is also non-toxic. But if it is heavy dose, then only we are going for the toxicity area. This is that N-acetyl para benzocunane imine. This student should clearly 2-3 times you have to remember and you should write. That is the very important point, because toxicology we are studying. NAPQI is a highly reactive and primarily responsible for acetaminophen induced hepatotoxicity. Detoxification of NAPQI is also possible, occurs through its binding to a sulfuryl group of glutathione, and it will be converted into acetyl para aminophenol, that is paracetamol, with glutathione, which is ultimately excreted in the urine as cysteine and mercapric acid conjugates. It can be excreted like acetyl para aminophenol conjugated with cysteine. It can be excreted. But if it is high dose, then only the problem arises. The student should remember this. Paracetamol conjugates first with glucuronides and sulfamates or sulfates, or not sulfates, metabolites. They are non-toxic, excreted in urine excretion. It can also converted by enzyme cytochrome P450 to the more toxic metabolite NAPQI, N-acetyl para-benzoquinone imine, and it can also be neutralized, or it can also be detoxified. Detoxification can occur by binding with sulfonyl group of the glutathione and can produce acetyl para-aminophenol glutathione, which is ultimately excreted as mercaptric acid, non-toxic, water-soluble compound, which can be excreted through renal excretion. So, this students should remember to write about the toxicity, basic behind what happens now. You can see, if it is excess dose, then only we will talk about the excretion will not be sufficient. It will go and damage the NAPQI. That is N-acetyl para-aminophenol is paracetamol. APAP, that is symbol wherever you have used, you should remember. Mechanism of toxicity of paracetamol now. This is where this you put one arrow extra. The NAPQ will damage and it becomes a hepatocyte necrosis, death of the liver cells by acetyl para-aminophenol paracetamol protein adducts oxidation stress to the cell, mitochondrial dysfunction, DNA fragmentation, and causes necrosis in liver. So NAPQI, usually you should write, tell again and again, what is this NAPQI? N-acetyl para-benzylquinone imine is the toxic metabolite produced from paracetamol in liver by cytochrome 450 enzyme. Can cause liver damage if it accumulates in the liver. Can you see that round? And when it exceeds the liver's capacity to detoxify it, we know that it can be also detoxified. I put one plus mark there. When it exceeds its capacity to detoxify it, it can react with cellular protein and make protein adducts and oxidative stress and mitochondrial dysfunction and DNA fragmentation and causes liver cell death, which is called hepatocyte necrosis. Easy for the students to write once you listen and understand. The risk of liver toxicity from paracetamol increases with higher doses, chronic uses, and consumption of alcohol is dangerous along with paracetamol. That's what they were asking in the question. What is the ethanol impact with paracetamol toxicity? Which can decrease the liver ability to detoxify. It reduces its capacity to detoxify this NAPQI. What is NAPQI? That is N-acetyl para-benzylquinone imine. The manifestation of the liver poisoning includes symptoms such as stomach discomfort, nausea, vomiting, and jaundice. So this is what the arrow which I want to show is consumption of alcohol can also decreases the liver's ability or decreases its liver's capacity to detoxify this N-acetyl para benzoquinine imine. So it is necessary for to avoid alcohol beverages once you take paracetamol. The symptoms and indication of acute toxicity, the signs and symptoms and clinical manifestation of acute paracetamol poisoning. So you should write some points. What are the symptoms? Number 1, nausea and vomiting. Everyone can write. But don't forget to write point by point. Nausea and vomiting. Number 2, you can see stomach discomfort localized mostly in the upper right quadrant. The upper right quadrant where the liver is placed. This is the place. There will be a discomfort and a pain. And number 3, you can see diminished appetite. Not interested to have food. And exhaustion and weakness, fatigue, tiredness, exhaustion or weakness can be seen. And number 5, perspiration, sweating in the armpit, sweating in the neck, sweating in the forehead, sweating in everywhere, unusual sweating. Perspiration will take place. Number 6, you can see cognitive impairment on somnolence or somnolence. Cognitive impairment, this will from the brain. Usually you can see in Parkinsonism disease, Alzheimer's disease patients, connecting the events or taking decision confusion and drowsiness. Somnolence means drowsiness can be seen in the patient with acute toxicity due to paracetamol. Number 7, in an extreme case, we can see even coma and or convulsions. This is in extreme cases. So these 8 indications, symptoms you should just mention. Very, very important in the subject. What is predictive factors for hepatotoxicity includes? We should know factors, predictive factors. Total amount consumed, it is needed for you to, if the patient is able to give you some information history, total amount consumed, time between consuming and a treatment is also very important for a factor to be predicted. Patient age, and alcoholism and the drug that induced enzymes, whether he has taken or is having a habit of alcoholism, you should see that. So total amount consumed, time between that is consumption and treatment, patient age, and then alcoholism and drugs sometimes they are taking which is inducing enzymes, it should be predicted. Toxic dose for liver damage in adult is 150 to 250 milligram per kg. Children under 10 exhibit great resistance to liver damage. Potential liver damage threshold should be known. Adult in acute dose more than 150 milligram per kg. Adult in chronic exposure 24 hours more than 7.5 grams 24 hours. And child under 10 years of age 200 milligram per kg. Acetaminophen toxicity can be divided into 4 stages. Paracetamol toxicity can be divided into 4 stages. One is 0 to 24 hours within a day. Individuals are asymptomatic or have minor symptoms such as nausea, vomiting, and stomach discomfort. You can find even elevated serum aminotransferase level AST and ALT, that is aspartate transaminase and alanine transaminase. This aspartate transaminase and alanine transaminase, if it is more elevated, then automatically we can find that liver is getting damaged and necrosis, liver cell necrosis will cause us immediately the increased level in AST and ALT. Number 2, 24 hours to 48 hours continued gastrointestinal symptoms. Right upper quadrant tenderness, discomfort in the right upper where the liver situated area, and liver damage becomes evident, marked by seeing that elevated, you can see that is elevated AST, that is aspartate transaminase and alanine transaminase levels, as well as the increased serum bilirubin also. We can see serum bilirubin. This also will be increased, even jaundice. And INR, that is international normalized ratio. What is this? INR, international normalized ratio, means it is a test which gives increased bleeding time, about the blood test. INR means it is related to the blood time, clotting time. Okay, that is what we should know. 72 to 96 hours, the third stage of the toxicity, if you want to see. Liver function continues to deteriorate. The patient may experience with jaundice, encephalopathy and coagulopathy, increasingly elevated AST, aspartate transaminase and ALT, alanine transaminase, further increase in serum bilirubin, jaundice, and INR, as I told, a blood test that measures how long it takes for blood to clot. So this will give you in the third stage. Fourth stage is very risky. That is more than 96 hours recovery or procession of liver failure. Clinical management of acute overdoses. How we are going to clinically manage now? We come to the last stage. Clinical managing with activated charcoal. Second one with acetylcysteine antidote using Rumac Matthew nomogram. You should know that Rumac Matthew nomogram, they may ask a short notes also. They are asking in other universities, what is the application of Rumac Matthew nomogram in treating paracetamol poisoned patient with antidote acetylcysteine, N-acetylcysteine, NAC they may say in short form. They have asked many questions, I have seen. So we should know what is the use of this Rumac Matthew nomogram. Very interesting. It is short. It is only an scientist he has given, that is Rumac Matthew, he has given a curve and by means of seeing the parameters, chemical tests, presence of toxic substance in the blood and treat with antidote. Simply, we cannot inject the antidote. Monitoring and supportive care is needed always in all toxicity studies, treatments we need. So there is three segments. Number one, with activated charcoal. Number two, with acetylcysteine, N-acetylcysteine antidote using Rumac Matthew nomogram. And number three, monitoring, various monitoring and supportive care. Number one, activated charcoal. We know that activated charcoal can prevent the absorption of paracetamol inside the circulating system. The optimal timing for administration is within a time frame of 1 to 2 hours after consumption. Number two, acetylcysteine antidote. N-acetylcysteine, usually they will say N-acetylcysteine, NAC. N-acetylcysteine is the antidote for paracetamol toxicity. It works by restoring glutathione, a natural occurring antioxidant that is depleted during paracetamol overdose. Treatment with acetylcysteine should be initiated as soon as possible. After ingestion of the overdose and can be given orally or intravenously. Measure a 4-hour serum acetaminophen concentration to assess the potential risk of hepatotoxicity using the Rumac Matthew nomogram. Rumac Matthew nomogram. The Rumac Matthew nomogram, it is the acetaminophen toxicity nomogram or acetaminophen nomogram. Like that also it can be told, the question can be twisted and they can ask. You should nomogram is a graph prepared by the scientist Rumac Matthew. Is interpret serum acetaminophen concentration usually in the y-axis relating to the time in the x-axis since ingestion in order to assess the potential that is hepatotoxicity. This is the graph. Single acute acetaminophen overdose nomogram. You see the line, dotted line, that is the Rumac Matthew line. And the line which is solid line, that is the treatment line. You can see the y-axis acetaminophen concentration in microgram per ml, 2, 3, 4, 5, 10, up to 500 it is there. And x-axis in hours, 4 hours, 8 hours, 12 hours, you can see a slope, declining graph, treatment line, which shows in 4 hours if there is 150 microgram per ml in the blood of acetaminophen plasma concentration. If it is more than that, treatment is needed. And then it will decline. In 24 hours, it comes to some 4 microgram per ml plasma concentration. You can stop. So, when to treat with antidote will be decided by this graph. It is a plot. The serum concentration of acetaminophen, paracetamol, against the time since ingestion. Generally, a serum plasma concentration of AP means paracetamol, acetyl para aminophenol of 140 to 150 microgram per ml or milligram per liter At 4 hours, post-ingestion indicates the need of NAC. What is NAC? N-acetylcysteine. Everywhere I told acetylcysteine as an antidote. It is usually called as NAC. The student should have an idea about NAC. They may ask, write about NAC. They may ask sometimes. Treatment. If half-life is more than 4 hours, half-life, that is kinetic study you might have studied. I am not going for that equation study. Half-life, the loss of the drug within half of the life, half-life of a drug in the blood, we might have studied in pharmacokinetics. So if the half-life is more than 4 hours, then treatment is necessary to prevent hepatotoxicity and liver failure. Number 3, monitoring and supportive care is also very important in a toxicology or toxicity, in acute toxicity of any drugs overdosage. It is essential to exercise vigilant monitoring of patients exhibiting paracetamol toxicity in order to detect any indication of hepatic impairment. This gives and support entails doing liver function tests, coagulation investigations. You should do liver function test, you should do coagulation investigation, and you should do serum electrolyte assessment, and supportive care should be given to the patient, including hydration, fluids, correction of electrolyte imbalances, and treatment of any complications such as hypoglycemia or seizures can also be seen. You have to treat. And there was a question, what was the use of oral methionine in treating paracetamol poisoning along with NAC, N-acetylcysteine. Oral methionine is as effective as acetylcysteine, NAC, N-acetylcysteine. Antidote, it's an antidote for paracetamol. Is preventing severe liver damage and death after acetaminophen overdose. However, as with acetylcysteine, it must be given. It must be given along with acetylcysteine, not allowed, within 10 hours of ingestion to be effective. This is the normal DL. Methionine tablets are also available in the market. So if the question I ask, you should remember about not only NAC, you should remember about methionine, you should remember about what all the toxicity. I hope this will be enough for the today, and we will continue with the next salicylate, non-steroidal anti-inflammatory drugs. We will continue with this class for our chapter because repeatedly they are asking questions. Thank you. Listen, prepare your own notes. You will no need to study before exam. You can write. Thank you.